Welcome to our second video on obstructive lung diseases. Let's begin. In this lecture, we will discuss asthma and bronchiectasis. Let's start with asthma. We will talk about the general features, pathophysiology, clinical presentation including severe life-threatening asthma risk factors, objective measures, and physical exam. We will also cover diagnosis and management of asthma. Asthma is an obstructive lung disease with intermittent symptoms. It is commonly associated with a personal or family history of atopy. Atopy is the genetic predilection to produce IgE following exposure to allergens. Some of the common manifestations of atopy are atopic dermatitis or eczema, allergic rhinitis, and asthma. Most of the time, asthma is a type 1 hypersensitivity reaction involving IgE, mast cells, and histamine secretion. Asthma is caused by bronchial hyperresponsiveness to various stimuli. Common triggers for asthma attacks include viral upper respiratory tract infections, inhaled allergens like pollen, and stress. Exposure to these stimuli results in reversible bronchoconstriction. Patients with asthma usually have bronchial smooth muscle hypertrophy and hyperplasia, which further narrow the bronchial lumen. These changes in the respiratory system occur over time. Let's talk about the clinical presentation of asthma. Signs and symptoms include intermittent cough due to bronchial irritation by inhaled allergens or other triggers. Tachypnea, dyspnea, and hypoxemia result from bronchoconstriction and decreased oxygen delivery to the alveoli. A decreased inspiratory-expiratory ratio means that the expiration takes longer than inspiration. The reason behind this phenomenon is bronchoconstriction and air trapping during exhalation. There may be mucus plugging due to sputum production in the bronchi. Let's talk about severe life-threatening asthma now. Risk factors for severe life-threatening asthma include poor control of the condition with frequent symptoms. Additional indicators of severe asthma include frequent emergency department visits, hospitalizations, and systemic glucocorticoid therapy. Finally, if the patient has been previously intubated for asthma, he or she is at high risk for future severe asthma attacks. Objective measures for a severe life-threatening asthma exacerbation include a pulse of greater than 120, respirations of greater than 30, O2 saturation of less than 90%, PaCO2 of greater than 45, and a peak expiratory flow rate of less than 50% of predicted. These findings indicate impending hemodynamic compromise and severe bronchoconstriction. Arterial blood gases may show acute respiratory alkalosis due to hyperventilation. Hyperventilation leads to removal of excessive CO2, which is how the patient can develop a respiratory alkalosis. Physical exam findings indicating a severe life-threatening asthma include severe dyspnea and accessory muscle use. Altered mental status can occur due to decreased oxygen delivery to the brain. Pulsus paradoxus is a drop of systolic blood pressure by greater than 10 during inspiration. Let's discuss how a severe asthma exacerbation can cause pulsus paradoxus. Diffuse bronchoconstriction during an asthma attack causes hypoxia. Hypoxia in turn results in diffuse pulmonary vasoconstriction. This increases the right ventricular afterload, so less blood is pumped in the pulmonary vasculature during systole. Instead, blood in the right ventricle pushes the interventricular septum towards the left ventricle, thereby decreasing the stroke volume. During inspiration, increased blood volume in the right ventricle pushes the interventricular septum even further into the left ventricle, decreasing the systolic blood pressure by more than 10. If the patient with severe asthma attack exhibits absent wheezing, decreased accessory muscle use, or normal PaCO2, it means that he or she has respiratory muscle fatigue and needs to be emergently intubated. A 9-year-old girl is brought to the emergency department due to severe shortness of breath and wheezing that started 2 hours ago. She was diagnosed with asthma 3 years ago. She did not take any of her asthma medications for the last 2 days because she forgot to take them on her camping trip. Physical exam shows the patient is in severe respiratory distress with scalene and intercostal muscle use. After several minutes, she becomes somnolent. Her respiratory rate normalizes, and the arterial blood gases show PaCO2 of 42. What is the best next step in the management of this patient? This patient with a past medical history of asthma presents with severe shortness of breath and wheezing. She did not take any of her asthma medications for the last 2 days. Physical exam reveals scalene and intercostal muscle use. All of these findings are consistent with the diagnosis of acute asthma exacerbation. After several minutes, she becomes somnolent, her respiratory rate normalizes, and her arterial blood gases show a PaCO2 of 42. This indicates respiratory muscle fatigue with impending respiratory failure. The next best step in the management of an asthmatic patient with respiratory muscle fatigue is intubation to maintain oxygenation. There's one type of subtype of asthma that we will discuss now. It is called NSAID-exacerbated respiratory stress, or NSAID-induced asthma. Let's discuss how NSAIDs can induce symptoms of asthma. NSAIDs can cause inhibition of cyclooxygenase pathway. Therefore, arachidonic acid is shunted to the lipooxygenase pathway, resulting in increased production of leukotrienes C4, D4, and E4. These leukotrienes cause bronchoconstriction, resulting in asthma-like symptoms. NSAID exacerbated respiratory distress is also characterized by chronic sinusitis with nasal polyp. Diagnosis of asthma is usually made via spirometry. If initial spirometry shows a FEV1-FVC ratio of less than 70%, one should administer an inhaled bronchodilator, preferably albuterol. If FEV1 increases by more than 12% or by greater than 200 milliliters, then the most likely diagnosis is asthma. If the FEV1-FVC ratio is normal, that is greater than 70%, one should administer a methylcholine challenge test. Methylcholine is a muscarinic receptor agonist causing bronchoconstriction. In patients without asthma, bronchoconstriction is minimal, and therefore methylcholine does not cause significant symptoms. However, if methylcholine decreases FEV1 by greater than 20%, then the patient has hyperresponsive airways, and the diagnosis of asthma is likely. It's worth mentioning that the chest X-ray and the arterial blood gases are usually normal in the patient with asthma, unless the patient is in an acute asthma attack. Here we have the diagnostic algorithm for asthma. If the patient has classic signs and symptoms of asthma, such as wheezing or shortness of breath, then we should perform pulmonary function tests. If pulmonary function tests show decreased FEV1, FEV/FVC ratio, and peak expiratory flow rate, suggesting an obstructive lung disease, then we should perform bronchoreversibility test with inhaled albuterol. During this test, we administer albuterol to the patient and then measure the change in FEV1. If FEV1 is increased by more than 12% after albuterol administration, asthma can be diagnosed and the treatment initiated. If the pulmonary function tests do not reveal an obstructive lung disease pattern, then we should perform a methylcholine challenge. Methylcholine is a muscarinic receptor agonist resulting in bronchoconstriction. A positive test shows more than 20% reduction in FEV1 after methylcholine administration. If the test is positive, then asthma is diagnosed. If the methylcholine challenge test is negative, then we should consider other diagnoses. One can also perform sputum microscopy in a patient with suspected asthma. Asthmatic patients have Kirschmann spirals in their sputum. Kirschmann spirals are created by shed epithelium forming whorled mucus plugs. Additionally, one can see Charcot-Leyden crystals in the sputum of the patient with asthma. Charcot-Leyden crystals are eosinophilic hexagonal crystals created by eosinophil breakdown in sputum. Finally, we can also measure serum IgE levels. However, this test is not routinely done because it does not confirm asthma. Here, one can see the image of sputum microscopy from the patient with asthma. On the left image, one can see the whorled mass consistent with Kirschmann spiral, while on the right image, one can appreciate the hexagonal eosinophilic double-pointed crystals consistent with Charcot-Leyden crystals. Asthma is classified into intermittent, mild persistent, moderate persistent, and severe persistent forms. Intermittent asthma is characterized by daytime symptoms less than twice per week, nighttime symptoms less than twice per month, and a FEV1 of at least 80%. Mild intermittent asthma, on the other hand, is characterized by daytime symptoms greater than 2 times a week, but not daily, nighttime symptoms greater than twice per month, and the FEV1 of at least 80%. Moderate intermittent asthma is characterized by daily daytime symptoms, nighttime symptoms at least once per week, and a FEV1 from 60% to 80%. Finally, severe persistent asthma has daily daytime symptoms, frequent nighttime symptoms, and a FEV1 less than 60%. Management of asthma includes a stepwise escalation of therapy depending on the severity of the symptoms. First, we need to prescribe short-acting beta-2 agonists like albuterol. If the patient requires maintenance therapy, we need to add low-dose inhaled corticosteroids. Only after starting low-dose corticosteroids can we prescribe long-acting beta-2 agonists like salmeterol or formoterol. It's very high yield to know that prescribing long-acting beta-2 agonists to the asthmatic patient who is not on corticosteroids yet increases overall mortality rate. If the patient's symptoms are still uncontrolled, we can gradually increase the dose of steroids, switching the patient from low dose to intermediate dose or high dose inhaled corticosteroids. At step 5 of asthma management, we can also consider omalizumab, reslizumab, mepolizumab, or benralizumab for the patient with severe allergic asthma. Omalizumab inhibits binding of IgE to its receptor, while the other 3 monoclonal antibodies interfere with interleukin-5 signaling. Finally, if the patient still needs the escalation of therapy, we can add oral corticosteroids to the patient's previous regimen. Please keep in mind that before we escalate asthma therapy, we should make sure that the patient is compliant with the current therapy and takes the medications the right way. Let's revisit the algorithm for asthma. When asthma is diagnosed, we start treatment with appropriate medications. Intermittent asthma needs only rescue short-acting beta-2 agonists. In mild persistent asthma, we should add daily low-dose inhaled corticosteroids. In moderate persistent asthma, we add long-acting beta-2 agonists. Finally, persistent asthma needs daily, medium, or high-dose inhaled corticosteroids with long-acting beta-2 agonists. Let's discuss bronchiectasis. For bronchiectasis, we will talk about its general features, pathophysiology, clinical presentation, diagnosis, and management. Bronchiectasis is a persistent, irreversible airway dilation. It is associated with behavioral risk factors and conditions causing recurrent airway infections such as smoking, cystic fibrosis, and Cartaginer syndrome. Cigarette smoke makes cilia relatively immobile, so the mucociliary escalator can no longer clear inhaled bacteria. These bacteria colonize the respiratory tract and cause infections. Cystic fibrosis and Cartaginer syndrome also lead to chronic issues with clearing bacteria from the respiratory tract and can lead to bronchiectasis. These pathophysiologies will be discussed more in depth later in the lecture. Let's talk about the pathophysiology of bronchiectasis. Recurrent necrotizing airway infections cause airway inflammation. Inflammation, in turn, results in the degradation of bronchial cartilage. Consequently, bronchi dilate and there is trapping of bacteria in the dilated bronchus. This predisposes the patient to self-perpetuating infections. Bronchiectasis is characterized by copious amounts of daily purulent sputum. As we already discussed on the previous slide, patients with bronchiectasis have recurrent lung infection. The most common causative pathogen of lung infections in these patients is Pseudomonas aeruginosa. Bronchiectasis is also accompanied by digital clubbing and hemoptysis. Digital clubbing is due to hypoxia-induced proliferation of connective tissue over the distal phalanges. Diagnosis of bronchiectasis is based on the combination of symptoms and imaging results. Imaging studies used to diagnose bronchiectasis include chest X-ray and chest CT. Chest X-ray usually shows reticular opacities consistent with dilated bronchi. Chest CT, on the other hand, commonly exhibits the signet ring sign consistent with the dilated bronchi with thickened walls. Here one can see the chest CT scan of a patient with bronchiectasis. Please take a close look at the signet rings corresponding to dilated bronchi. The large black arrows indicate two main stem bronchi, while the large white arrows indicate bronchial wall thickening. Management of bronchiectasis involves chest physiotherapy to clear the sputum. Additionally, if the patient has an underlying condition, one should treat that disease as well. Antibiotics are used for recurrent lung infection. Finally, one can perform lung transplantation if the medical management fails. A 75-year-old man comes to the physician reporting a cough productive of copious sputum for the last 5 years. The cough is purulent with occasional blood streaks. He has been smoking 2.5 packs of cigarettes per day for the last 40 years. Chest X-ray reveals bilateral reticular opacities, while high-resolution chest CT shows bronchial dilation and bronchial wall thickening. The physician diagnoses the patient with bronchiectasis and tells him that his condition is most likely due to the long-term smoking history. How does smoking increase the risk of this patient's condition? This patient presents with a cough productive of purulent sputum and occasional blood streaks. He has a long smoking history, and the imaging studies confirm bronchiectasis. Cigarette smoke causes immobility of the respiratory cilia. Therefore, inhaled bacteria are no longer cleared via the mucociliary escalator, and those bacteria cause recurrent infections. This is how a patient with long-term smoking history might develop bronchiectasis. And that concludes our lecture on asthma and bronchiectasis.